Welcome to the debate.
Glad to be here.
Today, we're dissecting a ghost. We're talking about a killer that is responsible for, 1 in 5 deaths globally, and yet it remains one of the most slippery diagnoses in all of medicine. We are talking about sepsis.
It really is the ultimate shapeshifter, isn't it? It's the condition that keeps every emergency physician awake at night. You miss it, and, well, the patient dies. You overcall it, and you're just fueling the global crisis of antibiotic resistance, subjecting patients to pretty toxic treatments they don't even need.
Precisely. And that tension, that line between missing the signal and overreacting to the noise, that's really the heart of our discussion today. We're looking at a conflict between two pretty distinct philosophies of care. On my side, we have the argument for precision. This is the view that without rigorous lab-based definitions, specifically the sepsis 3 criteria and the newly updated SOFA 2 score, we are essentially flying blind. We're treating ghosts instead of pathology.
And on the other side, which I'll be defending, is the argument for speed, for utility. Because in the chaotic reality of an emergency room, patients don't walk in with a dashboard of their liver enzyme levels printed on their forehead. They come in with symptoms. And I'm arguing that we have to prioritize clinical red flags and rapid bedside screening tools like Q-SOFA. They might be statistically imperfect, I get that, but they are the only tools fast enough to save a life in that golden hour.
So the battle lines are drawn. Is it better to be fast and potentially wrong, or slow and clinically precise?
I'd argue that if you aren't fast, you don't even get the luxury of being precise later. But let's ground this. Why don't you lay out the case for why biomarkers and scores, the quote-unquote slow route, are actually the only safe way to practice medicine?
Well, it comes down to the fundamental complexity of what we're actually treating. We throw around the word infection like it's a single monolithic thing. But biologically, the difference between, say, bacteremia and viremia is massive.
Sure, biologically. But clinically, in those first 10 minutes, they look identical. You've got a fever, fatigue, aches. I mean, a bad flu and early bacterial sepsis are practically twins.
That is exactly my point. If you rely on how they look, you are guessing. Symptoms are subjective, they're vague, and they overlap. A patient with severe influenza and a patient with early meningococcal sepsis can present with the exact same high fever and muscle pain. If you trust your eyes, you might pump the flu patient with vancomycin, or, even worse, send the sepsis patient home with Tylenol.
So you don't trust the eyes, you trust the numbers.
I trust the biological signal. We need to see the pattern. Bacterial infections, they typically drive a very specific cascade, a high white blood cell count that's dominated by neutrophils, an elevated C-reactive protein, usually spiking over 50 or 100 milligrams per liter, and, crucially for our discussion, high procalcitonin.
Procalcitonin being the more specific marker for a bacterial origin.
Exactly. It's a peptide precursor that just skyrockets in response to bacterial toxins, but is actually suppressed by viral infections. That is a clear binary signal in an otherwise noisy biological system. Sepsis isn't just being sick. Per the sepsis 3 definition, it's life-threatening organ dysfunction, and you identify that by measuring the dysfunction, not by guessing at it. We need the SOFA score. We need to see a change of 2 points or more, and that requires bilirubin, creatinine, platelets, arterial gases.
It requires a full workup.
It requires data. Without that data, we aren't practicing medicine. We're practicing intuition, and intuition kills.
See, I respect the rigor of that. I really do. In an ICU, 3 days into an admission, I'm with you 100%. But I'm speaking for the clinician who's standing at the bedside at 2 a.m. on a Friday when a patient rolls in. I don't have a creatinine level. I don't have a procalcitonin. I have a human being who is deteriorating right in front of me.
But are they deteriorating from sepsis or from heart failure or a pulmonary embolism?
That's the wrong question for the first 15 minutes. My core thesis is that while labs provide intellectual certainty, they offer it too late. Sepsis is a time-critical emergency. Every single hour of delayed antibiotics increases mortality. If I wait for your perfect SOFA score, the patient might be dead before the lab printer even warms up. We have to value the physical exam and the red flags.
Red flags are often just red herrings.
Not always. Take a classic example, meningitis. If a patient comes in with a splitting headache, a stiff neck, and photophobia, light sensitivity, I don't need a lumbar puncture to tell me that brain is in danger. Those are the physical signs of meningeal irritation.
The classic triad.
Yes. And if I see a non-blanching purpuric rash, that terrifying purple rash that doesn't fade when you press a glass against it, I am treating for meningococcal sepsis immediately. I am not waiting for the lab to tell me the white count is elevated. The rash is the diagnosis.
Okay, I want to push back on that specific example because it illustrates the danger of your approach perfectly. You mentioned the triad: headache, stiff neck, light sensitivity. It makes for a great textbook case. But in reality,
that triad has incredibly low sensitivity.
it doesn't catch everyone, sure. It misses a lot of people. And conversely, viral meningitis, which is self-limiting and rarely fatal, can present with those exact same signs. If you treat based on neck stiffness, you are treating a lot of viruses with heavy-duty antibiotics. To truly differentiate, you need the gold standard. You need the lumbar puncture. You need to analyze the cerebrospinal fluid for low glucose and high protein.
I'm not saying we skip the LP. I'm saying the trigger to act is the sign, not the lab.
But the sign is unreliable. Let's pivot to pneumonia. You listen to the lungs. You hear crackles. Is it bacterial pneumonia, or is it heart failure? Or pulmonary fibrosis, or is it COVID?
You can usually tell from the history.
Usually isn't good enough. To distinguish bacterial pneumonia from viral pneumonia, you cannot rely on your stethoscope. You need to see the dense consolidation on a chest X-ray. You need that procalcitonin level we discussed. If the procalcitonin is low, it's likely viral. If you treat that patient with antibiotics based on crackles, you are doing harm. You are disrupting their microbiome and ignoring the actual viral cause.
That's fair regarding pneumonia. The lungs are noisy. But let's look at the kidney, pyelonephritis. The material is very specific here. Costovertebral angle tenderness. You tap on the patient's mid-back. If they jump off the table in pain, that is a highly specific red flag for a kidney infection.
It is specific for pain. It could be a kidney stone. It could be a musculoskeletal strain. It could be an abscess. To confirm pyelonephritis, an infection of the kidney tissue itself, you need the urinalysis. You need to see white blood cell cast under a microscope. That is the smoking gun that proves the infection has ascended from the bladder. The physical exam gives you a hint. The lab gives you the truth.
I think we're circling a fundamental difference here. I view the hint as the call to action. You view the truth as the prerequisite for action. And this disagreement scales up perfectly to the battle of the scoring systems themselves. We need to talk about SOFA versus QSOFA.
We certainly do. This is where the rubber meets the road in terms of, patient safety versus hospital logistics.
For our listeners, let's just clarify. SOFA is the sequential organ failure assessment, the complex lab-based score you love. QSOFA is quick SOFA. It uses three things: respiratory rate greater than 22, altered mental status, and systolic blood pressure of 100 or less. No labs, no needles, just looking at the patient.
And it is a deeply flawed tool.
It's a triage tool.
It's a tool that misses sick people. We have to look at the data. In ICU settings, the full SOFA score is robust. It has an AUROC, the area under the receiver operating characteristic curve, basically a measure of how well it predicts mortality, of roughly 0.75 to 0.84. That is a solid, well-calibrated instrument. QSOFA scores significantly lower. It has poor sensitivity.
I won't dispute the sensitivity numbers. QSOFA misses patients who are, compensating well.
It doesn't just miss them, it dismisses them. A patient can be in profound organ failure, their platelets dropping, their liver enzymes spiking, but if their blood pressure is 105 and they are breathing normally, QSOFA says, you're fine. That is dangerous. Sepsis 3 defines sepsis by organ dysfunction. QSOFA ignores the liver, it ignores platelets, it ignores the kidneys until they completely stop making urine.
It ignores them because I can't see the liver with my naked eye. You're judging a screwdriver by its ability to hammer a nail. QSOFA was never meant to replace the full sofa in the ICU. It was designed for the waiting room.
But if it fails in the waiting room, people die at home. But consider the alternative. To calculate your perfect SOFA score, you need a PaO2-FiO2 ratio. Do you know what that requires?
An arterial blood gas. Exactly. You have to stick a needle into the artery in the patient's wrist. Are you seriously suggesting we do an arterial stab on every single person who's coughing in the waiting room before we decide if they're sick? That is clinically impossible. It's fantasy. Q-SOFA allows me to walk down a line of patients and say, you, and you, get to a bed now. I would rather catch the visibly crashing patients instantly than wait 2 hours to realize someone's creatinine is a little elevated.
I understand the logistical argument. Truly. But I would counter that we are moving toward a world where we don't have to choose between speed and accuracy. And this brings us to the major development in the source material, the 2025 SOFA 2 update.
Ah, the new gold standard.
It is a vindication of the data-driven approach. This update, published late in 2025, overhauls a system that hadn't been touched since 1996. Think about that. Medicine has changed completely in 30 years, but we were using the same score. This new version validates the score across 3.3 million patients. That is a staggering amount of data.
It is a massive data set, I'll grant you that. It's hard to argue with 3.3 million data points.
And it fixes the exact problems you are worried about. The old SOFA score was criticized because the cardiovascular section relied on dopamine dosing.
Which we barely use anymore.
Right. In 1996, dopamine was a standard pressor for sepsis. Now we know it causes arrhythmias. We use norepinephrine, we use vasopressin. SOFA 2 updates those thresholds to reflect modern practice. It even accounts for ECMO in the respiratory section. It is a modernized, calibrated instrument with an AUROC of nearly 0.79. It proves that the solution to sepsis is hard isn't to dumb down our tools with Q-SOFA, but to sharpen our tools with better data.
That's an interesting point, and I'm glad they updated the drugs. It was absurd to be scoring patients based on, 1990s protocols. But I want to peel back the curtain on SOFA 2 for a second. Have you considered what they didn't change?
You mean the organ systems?
Exactly. Despite 3.3 million patients, despite 30 years of progress, the sepsis 3 definition itself remains unchanged. Sepsis is still defined by that delta of 2 points. And significantly, look at what they left out. They evaluated the gastrointestinal system. They evaluated the immune system.
And they excluded them.
They excluded them. They said there wasn't enough consistent data. So here we are with our shiny new SOFA 2, and it still ignores the gut, which we know is the engine of sepsis in many cases, leading to translocation of bacteria. It ignores the immune system's paralysis. This implies that even our best model is still incomplete. We're quantifying the failure we can measure, but are we capturing the full biological reality?
Well, that's the discipline of science, though. We are capturing the measurable reality. The exclusion of the GI and immune systems wasn't an oversight. It was a commitment to statistical validity. If you can't measure it reliably across 3.3 million people, you don't include it in a global definition. That prevents noise. SOFA 2 ensures that when we say a patient has cardiovascular failure, we're using definitions that match 2026 practice.
I agree it's an improvement. I'm just cautioning against hubris. The score is a map, not the territory. Just because the score doesn't show gut failure doesn't mean the gut isn't failing. And speaking of territory that maps often fail to cover, we need to talk about the edge case that trips up both clinical signs and scoring systems, viral sepsis.
This is crucial. We often default to thinking sepsis equals bacteria.
Right? We think of an infected wound or UTI, seeding the blood with bacteria. But as the material highlights, viremia, viruses in the blood, can lead to sepsis too. We saw this with severe COVID. We see it with dengue.
And this is where the antibiotic reflex becomes so dangerous.
The urge to just throw vancomycin and Zosyn at anyone with a fever and low blood pressure?
Exactly. Clinically, viral sepsis and bacterial sepsis can look nearly identical in the early stages. Fever, hypotension, confusion. If you rely on your physical exam, you will treat that viral patient with antibiotics. You'll do nothing for the virus, but you will harm the patient's microbiome and breed resistance. This is where my argument for precision provides the only clear path.
Because of the labs?
Yes. Look at the white blood cell count patterns. Bacterial infections typically show leukocytosis, high white cells, specifically with high neutrophils. Viral infections, they often show normal or even low white blood cells, or a dominance of lymphocytes. If you have a patient with sepsis physiology, low blood pressure, high lactate, but their white count is low and their procalcitonin is normal, you are likely dealing with a viral cause.
And knowing that allows you to hold the antibiotics?
It gives you the confidence to hold them. Without the lab data, withholding antibiotics feels reckless. With the data, it becomes rational medicine.
That is a fair point. The risk of overtreatment is real. But let me play the advocate for the patient again. The risk of undertreatment is death. If I see a patient with dengue who is going into shock, I am treating the shock. I'm managing the fluids. I'm supporting the pressure. The differentiation is important for the antibiotics, yes. But the recognition of the septic state, the fact that they are crashing, is clinical.
We agree that recognition is the first step, but recognition without precise characterization leads to sloppy medicine. We can't just treat sickness. We have to treat the specific physiological failure.
And precise characterization without timely recognition leads to a very rigorous autopsy.
Tache? But I think we are approaching a synthesis here.
I think so.
We've covered the reliability of symptoms, or lack thereof, and things like meningitis. We've fought the battle between the comprehensive SOFA and the rapid QS SOFA. We've analyzed the new SOFA 2 update. Where does this leave us?
For me, it reinforces that while biological precision is the ultimate goal, medicine is practiced in the real world. We cannot just discard tools like QSOFA or the recognition of red flags like that non-blanching rash just because they lack statistical perfection. They're the smoke alarm. The smoke alarm might go off when you burn toast, but you'd rather have it go off too often than not at all when the house is actually burning.
I accept the smoke alarm analogy, but I must insist that once the alarm goes off, we not just spray water blindly. The SOFA2 update proves that the medical community is moving toward more data, not less. We are refining our definitions to match our capabilities. We have to rely on gold standards, cultures, imaging, comprehensive scoring to actually save the patient, not just stabilize them.
Perhaps the perfect system is one that uses the speed of the dissenter to buy time for the precision of the advocate.
I can agree with that. It's the balance between the art of recognizing a sick human being and the science of quantifying their biological failure.
And having the wisdom to know which tool to use and when.
Precisely. There is clearly much more to explore in this material, particularly how these scores will evolve as we start integrating things like AI and continuous monitoring in the future.
But for now, check your patients and then check your labs.
Thank you for joining the debate.
See you next time.